Hello everyone, welcome back to our 11 o'clock session of today's virtual learning exchange. So our next presentation is on the topic of what are the mental health and substance use information needs of newcomers and their supporters. And our presenter with me here today at AMSA is Sarah Hamid Balma. Sarah is the Director of Mental Health Promotion at the Canadian Mental Health Association's BC Division and has been working in mental health education for the past 17 years. She has a master's degree in public relations with honors specializing in health communication. In her role at CMHA, she is a senior project manager overseeing a department working on various province-wide initiatives that support mental health education and health literacy for various populations. She is also trained to provide information, support, and referral to people in distress. With colleagues at the Centre for Addictions Research of BC, University of Victoria, she has been working on an ongoing priority area to support the mental health and substance use education needs of newcomer British Columbians whose primary language is not English by supporting the needs of professional intermediaries in the settlement and multicultural sector. Sarah is an immigrant to Canada and as a young child was a refugee. So thank you so much for joining us, Sarah, and we're looking forward to hearing your presentation.
Thank you for having me. I hope everyone can hear okay. So yes, I work at CMHA, Canadian Mental Health, and we are a provincial nonprofit. And yes, as a former immigrant and child refugee, I know firsthand that mental well-being is always at stake in resettlement, but perhaps the stakes are a bit higher now with everything happening in the world. So I'm just going to walk through what we're covering, what I intend to cover in this webinar, and what our initiative is, what our process was, and then cover the 2 consultations that we did with people like you in the working in the multicultural and settlement sectors, and then go on to next steps and opportunities and our priorities moving forward on how we can better support you, and hope to engage you in that work as well. So for background, again, I'm here representing CMHA, but I'm also here representing a coalition called the BC Partners for Mental Health and Addictions Information. And we came together for some of our work in 2003, and you can see that we're a group of 7 provincial nonprofits. And that'll come up on your slide right now, providing good quality information to promote mental well-being and to help individuals and families better prevent, recognize, and manage mental health and substance use problems. And you can see that I work with that first logo there, and my partner at the Centre for Addictions Research of BC, I'm presenting on her behalf as well. So we're the 2 lead agencies of the 7 that are embarking on this work. So what is this work actually? Well, in 2016, we began a process to actually review the next steps for some of our multilingual resources on our website. And that's how this all actually began. And for some of you who don't know the history of those materials, just very briefly, in 2005, and between 2005 and 2007, a group outside of our coalition, actually including Dr. Gannison, who just spoke, undertook a very large-scale translation project and chose a number of our brochures and info sheets to translate into 11 languages. And to give you a sense of the scope, there are 220 materials available today that were done as part of that project, using a very culturally sensitive approach and community-driven. Now, at this point, they're a decade old on average, and they're overdue for review, and virtually all the English equivalents have long since been retired, and really, frankly, none of them were written or designed for non-English speakers or for newcomers, and they had other shortcomings as well. And so before we thought about updating them, which is really a big piece of work in terms of time and money to do that well, we thought, well, why don't we actually talk to people who work directly with newcomers and find out what would be more helpful, what would make sense, what do you need now in 2017 that would help you do your work better and help us improve. Our goal really is to improve the health literacy, the information needs of people, of newcomer, immigrant and refugee newcomers. So that's how we began this work, to realize, we better do something with these materials, and then why don't we actually talk to community. So again, our goals were really to understand the needs related to linguistic and culturally appropriate resources, and to prioritize and inform the development of what we were going to do next. And so we embarked on 2 consultations. So the first consultation was for a key informant approach, which is a fancy way to say that we interviewed a bunch of really great people, ranging from program managers and settlement workers to mental health clinicians, primary care practitioners. Dr. Gannison was one of them, many, many others. We did that early in 2016, and we asked for about 20 minutes of their time, and for the majority of them, we got well over an hour. They were very hungry to talk to us about what is helpful, what would be helpful. And we talked to representatives from such organizations as AMSA, ISS of BC, Mosaic, Success, VAST, Diversity, and many, many others. Just wanted to give you a sense of the range that we talked to. And we did include someone from the Indigenous community, but since there are certain non-English speakers in that community as well. But we quickly realized that although many of the needs are similar with Indigenous people, they're definitely not newcomers. We realized we were going to need a separate strategy and tailored resources for that community. But I think what we do with this work will really inform how we can actually better support Indigenous people who have some of the same needs. So the second consultation was more recent. It was in the fall, in November, and we presented the findings from the first one as well as asked some more specific questions. And we had participation from around 30 people. Some of you listening to this may have been part of that webinar or not. And we actually had so much discussion in that webinar. My colleague Betty and I were actually really humbled and surprised. We had to stop the discussion at several times just purely for lack of time. People had so much wisdom to share, a lot of appetite to know more, and a really strong desire to connect more with each other in their mental health work. Feeling a bit isolated, I think, in that sense of not being able to meet regularly to talk about this difficult work. So I'm going to talk about what we found in the first consultation was the biggest piece of work, what we found, and I should just sort of preface it by saying that a lot of it, given where you work as frontline staff out in settlement work and multicultural, multilingual support, it's not going to surprise you when I'm going to present. I probably won't, but some of them might if you work maybe less directly with newcomers yourself, or if you work for one specific audience or one cultural group. This bigger picture view may be helpful to you, and it also is another way for us to check if we got it right, if we listened right, and to connect even more people in this sector to our work to help us know how to do this work better as we move forward. So, consultation 1. So, next slide, please. So, and you can drill down all of those ones. So we had 7 major findings for consultation 1, and I'm just going to show them here, and then I'm going to do one slide on each of them just to give you a little bit more sense. But from all of our piles of interview notes, we had these 7 themes emerge, and I'm just going to go into some of the concrete examples and the feedback in the next 7 slides. I'm sure that I will hear the nods, you know, if I could hear nods through the microphone. The first one had by far the most commentary, so I will spend the most time on this next slide, but and you'll probably understand why. So next slide, please. So our first key theme was really a recommendation to us, was to really ensure that resources, whatever shape, you know, there might be brochures, it might be a video, it might be, you know, we're using the word resource very, very broadly, that they're culturally relevant and appealing. And the why about this is important. If you can go backwards a little bit, just to the very top. One more. Perfect. So the why of this is really around, you know, well, mental health and substance use are difficult topics for many groups to approach, and they're difficult for Canadian audiences, Canadian-born audiences as well. And sometimes you're going to have just an extra layer upon layer of stigma, of harmful beliefs and attitudes and values, and of course discrimination as well. So this is hard stuff to talk about, but we really wanted, or really heard, that people need to feel safe enough to engage with these topics and materials, and they reminded us that really everyone comes to this with their own ideas and perceptions of health. No one comes with a blank slate, no matter where they've been coming from, and that's going to affect their help seeking and their recovery. So then we heard about how do we address it. So one of the first things we heard was really to avoid a tone that assumes that the Western model is best, or that even mental health is a concept. You know, we heard mental health is not a universal construct. Many of our interviewees told us, you know, some cultures, and certainly this this came home for me because I could relate to, I'm not Canadian born, and I have family members who have very different conceptions of mental health, but many cultures don't recognize mental health as a health issue. Some cultures don't recognize health as a continuum. You're either sick or you're healthy. There's nothing in between. And of course, we know many cultures have different interpretations of experiences that Western medicine would consider an illness, or would put in a sickness box that another culture would not put there. And we know that there's a greater chance someone's going to access and understand and act on information if it fits into their worldview. And so if we try to just steamroll through that and pretend that that worldview is not as good or as evidence-based or whatever rationale we give, we are going to shut down that interaction. So next slide. So we also heard about really building on what's already in place and what's there already, and build on the strengths and all the resilience that newcomers are coming with and the supports they have naturally. So for example, they told us to avoid dismissing things like spirits or magic if that plays a role in how they understand or manage a mental health topic. So to use things like yes and consider this instead of no, but why don't you think of this other better thing. So they said use a yes and approach, not a no but or a no it's, and we're going to get more engagement that way. Dismissing someone's ideas was just going to shut down that interaction. So, and we also, part of the building on what's already there is really around finding ways in, to find appealing ways. For example, if a parent, if we can encourage self-care, mental well-being self-care for a parent, with the idea that then they can better take care of their children, that might actually be a good way to motivate someone to pick up a material if it's framed in that way. And of course, reflecting cultural context in the images and the metaphors and the vocabulary. If depression isn't the word that a group uses, well, what is their framework for describing that phenomenon? And use that framework instead, and not try to, we might introduce the term later on, but really it's about trying to relate their concepts and creating a bridge to how it's discussed here. And again, avoid absolutes as well. We heard a lot that referencing religion and spirituality is helpful. It could certainly help many people, but that it's not going to necessarily help all people, and in some cases may do harm. And we know that there are religions and religious faith leaders who may increase shame or discourage help seeking or even certain treatments, and we know that's not uniform, but that can happen, and so we have to be careful how we recommend those things. Then it's about talking about mental health in the context of overall health. So connecting it more to wellness and physical health in general. The next one. Normalizing. We heard a lot about, getting beyond talking about illness, but really framing things like trauma, things that you're already seeing, trauma, anxiety, stress, grief, low mood, as part of the settlement process, as part of the shared humanity, instead of catastrophizing it or labeling it as illness. And then again, on that same theme, focusing less on disorders and mental illness. There may be need for that later on, but again, more on sort of managing in daily life, and recognizing that not just health, but health services might be viewed and trusted differently. So a government-run system might be feared or seen as corrupt in some countries, and so espousing our government-run system as a great place to get free health care here might need more context so that there's some trust there, because that's not necessarily a good thing where in someone's country of origin. So in our next one around literacy, so that was the one, again, we heard the bulk about, and these ones I'll be much more brief. Pay attention to literacy. Again, of course, information has to be understood or we can't really do anything with it. And we definitely heard that newcomers are not going to be just ones volunteering to disclose that they have literacy challenges. So we need to bring the reading level accessibility lower to reach those who will never disclose that they have a literacy challenge. And we also heard numerous times that for many languages, or maybe for some languages, there are either no interpreters or few interpreters, or their interpretation service, the quality varies. And so we need other ways to communicate health information that don't rely as much on text. And so the advice they gave us in terms of how we can address it would be to, de-emphasize written materials and use lots of visuals. Use illustrations over photos in the visuals because that can be a little bit more inclusive. And people can see themselves a little bit more. Design materials as memory aids after a face-to-face visit. So one primary care practitioner at the newcomer clinic told us about, how great it would be if a drawing that she used to describe a process in the body during their clinic appointment could be available as a reference, to take home so that they could remember what had been discussed. And that way she was able to focus more on the conversation and less on trying to take notes or draw pretty diagrams. So thinking of materials in that way. Making sure whatever we do is brief, simple, and repeats key messages, and this is good practice for any audience. And finally, to explain anything that could be unfamiliar and really looking at any word, even a word like settlement worker may be unknown. It might be very well known in our sector, in your sector, but not very well known to someone new here, and what the role of that person is, or even something like a family doctor or a GP or primary care, or a lot of these words, public sector, that we throw around without stopping to actually think, what does that mean and how is that perceived? The next slide is around sort of, major theme, and really actually the priority area that we're moving the most towards is really, please give us some more supports. We're the ones that are doing a lot of these face-to-face conversations, and so in our report we called people like you who are listening intermediaries in our report, because you're professionals who are trusted supporters. And so it could be people who are like settlement workers, but it could also be family doctors, faith leaders, or others outside this sector. And of course, we have heard over and over again in our consultation that newcomers often go to settlement workers and other intermediaries when they need help because you're trusted. And they might even go to you with health questions, even if that's out of scope, because they know you. And we heard over and over that face-to-face interactions are the most effective way to exchange information and support. And given the last slide we talked about literacy, that print materials aren't always appropriate for, again, for all the literacy level issues that we mentioned, and that they don't really relate or see themselves in print materials the way they do in a face-to-face conversation. And so given you're having so many of those face-to-face conversations, how can we help people like you doing that work to support mental health and substance use related questions better and give them better tools, and support your own learning to give them better answers? So the advice we got here was around supporting culturally safe conversations that acknowledged different experiences with health or social or justice. Now this is a little bit less folks in settlement, so I should explain that this was informants who discussed a real need for intermediaries like healthcare providers or family doctors or psychiatrists, or people who work outside of the settlement system but who still interact with newcomers. A really poignant example someone gave us was a newcomer who may be referred to their family doctor but may not feel comfortable disclosing mental health or substance use challenges to that person because of the way that people with those experiences are treated in their country of origin, right? So they're still really scared about what's going to happen. They don't have that level of trust. And the GP may not know that context and may not know enough to create that space of trust for that conversation to happen, and so it never gets discussed. And so there was a lot of conversation around how can we support people like GPs, psychiatrists, pharmacists, people who are having these conversations to know more about some of these fears and challenges. And then we also want to make sure that we acknowledge that newcomers often go to settlement workers and these other intermediaries, these professionals, when they need help, and they're not going to websites and they're not coming to us over in mental health. And then finally, we asked the people we interviewed, what kind of support would you appreciate? What kind of topics do you want to know more about? And some of the things you told us were, provide good information on mental health impacts of settlement. And I think Dr. Gannison is a great resource there, and one of the reasons why he came to speak today. Some more support on system navigation, because that's something that you get a lot of questions about and is hard for Canadians as well to figure out. And maybe some support to also examine your own beliefs, all of our own beliefs around mental health and substance use. We all come, again, with our own preconceived notions around these issues, and it's important to look at our own values, what assumptions we have, which areas we know more about. Maybe we know more about trauma and we know more about anxiety, but we really don't know a lot about how drinking is an issue in our with our clients. So I think it's doing a bit of a reality check around what we need to know more about in our sector. And so that was what we heard about in terms of increasing support and capacity there. And then the next one around prioritizing resources around navigating the system, which I already sort of mentioned. Again, people with first languages that are not English are going to face even more barriers getting around. And we heard a lot, and again from our Indigenous consultant, that this kind of information is useful not only for newcomers, but this would be useful, we could repackage it for many other BC audiences, including Canadian-born, English-speaking, and Indigenous audiences. So the advice they gave us is really over and over again to acknowledge a person's capacity to realistically act on the information. And I'll give you an example. In a lot of our English language sheets that we write for Canadians, we might end a resource by saying, as a next step, go to see your doctor. Well, if writing something tailored to this audience, simply telling someone to go to their doctor isn't helpful when there's so many steps to consider. How do you find one? How do you remember the appointment? Finding and traveling to the office and transit and parking and all of that. Trusting and talking to the doctor, understanding what the doctor-patient interaction looks like here in Canada. And then, so they told us that resources should really answer questions like, how does the health system work here? Not the mental health system, how does the basic health system work here? There isn't enough information about that. That is very, very plain language. How do you recognize symptoms and ask for help, ask questions, or advocate for yourself or a loved one? Many cultures really defer to authority and are very silent in those interactions, and they don't know that they can ask questions or ought to ask questions about what they're hearing back if they don't understand. And, you know, and basically, and how will someone take a prescription that they might be given, and what do they do with that? And can they afford the prescription? Do they know what to do and all the systems they have to engage with to take the next step? So that just a simple visit to a doctor is a huge undertaking and could be a resource in itself just to unpack that. And finally, our sort of last few were around, so you can see here again, telling someone to go to their doctor isn't helpful on its own, and we really need to break down how some of those systems work. Next slide, please. So then we heard in our, I think this is our fifth of 7, really working in partnership with communities, and again, that's why I'm here, and why we did these 2 consultations so far when developing resources. You know, we're not the experts in this area, and that they told us that we need to keep checking that we've got it right and not over-consult, but just to make sure that that we invite and work in partnership with key people in the community and invite them to be part of it, and that settlement workers in particular are a really key group to engage, as well as primary care folks who are working directly in newcomer and refugee clinics. Because when you have that trust and respect and they understand why we're doing this work and we're doing it on their behalf, essentially, they're more likely to endorse it, to share it, and really fundamentally to use it themselves in their face-to-face conversations, and that's really what we want. So, so the next bullet around dissemination, and again, intermediaries like you, professionals like you are a key resource for us to actually spread whatever resources we end up developing with you. And some advice that we got, the first one we got around how to better spread the word when we do produce something is, you know, rely less on websites. So they told us that websites might be a great repository, but they probably shouldn't be the primary way to disseminate any resources we create. Using websites for health information may be limited even in someone's native language. They might not go online to look for that. And really that web use depends on really a lot of things, including their age, their literacy, their online skills and confidence with computers, internet access, even internet speed. All those things are going to be a factor. And that if we want to do something electronic, that apps for phone may be preferable to websites. And then we also heard some things that are just good practice in public health and public education. Give core information over multiple channels. You have to repeat the message many different ways through many different means to get to people. And then finally, that, you know, we can only use these like media channels, and fundamentally newcomers want a relationship with the people that they're getting information from. There's only going to be a limit to the TV ads, radio ads, bus ads, websites, that really the best disseminator of information isn't a channel, it's a person. And finally, we asked, because we didn't know if we'd get consensus around, which particular language and population groups should we be looking at, and who has some higher needs that we haven't heard about. And why is it important? Before I sort of say what people told us, again, there are fewer interpreters and translated resources available for those who speak languages with lesser diffusion in BC, so those languages that have fewer native speakers here. And very often, and governments are, we're not government, but very often when looking at multilingual work in particular, it's very tempting to want to go to where there are the most speakers of a language because you'll have the most potential reach. But, and Soma is one who's always told me, he says, just because there are a lot of speakers of a language in BC, for example, traditional Chinese or simplified Chinese or Punjabi, doesn't always mean that the highest need is there. They may already have more supports in that community, and that the measure really should be less about the diffusion of the language and more around the supports that they have and where they are in settlement and in their mental health needs. And they've also reminded us that newcomers, and I remember this from my own family, initially relieved having made it to Canada, you're not going to often experience or even be ready for mental health information until at least a year, sometimes longer, after you arrive, because you're so busy with housing and income and school and family settlement that you don't actually feel or think you have the luxury to think about things like mental well-being or health until much later. So the timing of when we reach and how we talk about it is also really important. So what they told us was really immigrants and refugees have similar but not identical needs, so to not lump them together too much, except where they do have similar needs. To consider specific audiences like parents or older teens. Younger children are able to adapt for all the reasons that younger children are awesome. They're able to adapt and learn more from school environments. But older teens, for example, are going to need support a little sooner around like growing up in a new country and how to negotiate relationships and fitting in, and the role of alcohol and other drugs, and all of that is a little bit messier for that age group. And that targeting parents is a really good way to reach the whole family, as we all know, including the older adults, because they're often the health seekers anyway. Not always the moms, but often the women in the family who are there looking for themselves, their spouses and partners, their children, and their parents, and the aunties and uncles that might be coming too. So, and the next thing they said is, instead of translating first, maybe consider low literacy English, or I should say low text English, and whatever text there is low literacy, as a bridge to selected translations later on. And of course, to use cultural adaptation and community processes when translating. That translating directly from English to another language is rarely effective, and that we already knew because the original project had used a very community-driven process. But we've seen very poor translations done in mental health. Certainly in my time at CMHA, I've seen things happen in Ontario and other places where people cringe at seeing the translation because it wasn't done through a community process. So we know that if we ever go down that road, it would be very low text, but that we have to do it in a very thoughtful and adaptable way. And then we asked the $60 million question of which particular cultural or language groups have the highest needs or particular needs. And not surprisingly, there wasn't a clear consensus that emerged, but the list that I've put up on the slide was the list that came up in terms of some of the groups that we might want to give some special focus to. And people reminded us again that groups are not homogeneous. Even with a common language, if we produce something in Spanish, it's going to not reach someone from Colombia in the same way that it reaches someone from Mexico or Spain. That we really, language is one way in, but we need to think beyond language to language and a particular cultural group or context. And then the more targeted we get with that, the more likely that people will see themselves in the material because it's being spoken to them and not just them as someone who can read Spanish. So I'm just winding down. The last couple slides are really just around our consultation too, which was, we just did that webinar in November that was an hour long, and we presented some of these findings, and then we asked, quite simply in the next slide, We asked what were some additional ideas. We asked people for their wish list of what other training things could we help them access around mental health or substance use. And so this is the feedback, and you can just pepper that whole thing down. We heard that a lot of people wanted more practical hands-on learning, that they'd had a lot of intellectual or text-based learning, but they wanted actually to practice, do role plays. They wanted ongoing workshops over time because, you know, might be a new group that comes, and then, you know, something that is responsive to changes that are happening in settlement. And they wanted to learn how we can train and support other health professionals in a respectful way who might have less understanding of newcomer issues. We heard several times that they want more support and maybe more peer support as well around coping with vicarious trauma, especially people who work with refugees, and hearing a lot of their traumatic experiences, and then how to do that without getting burned out or traumatized yourself. And then we heard from managers who support people like that who aren't doing those stories, but they don't know how to debrief that in a safe way. And they reminded us that in the settlement field, debriefing isn't a normal practice like it is in counseling and social work and mental health. So, and I think there's some power to leverage some peer support in having people debrief, because it is very, very traumatic work if you're hearing those stories over and over again. And then we heard some very basic questions like, how do I deal with someone in crisis right in front of me when I don't have a mental health background? And we heard very advanced questions too, like, you know, I want culturally validated assessment tools for depression that are available in different languages, and also assessments around psychosis that are culturally appropriate, and around suicide risks. So we had people with counseling backgrounds who wanted much more advanced competencies, and there were people who had very basic things that they needed because they didn't come at it from a mental health background. And fundamentally, we heard that from a couple of people that they really wanted that, like a community of practice, which is really a group of people who are doing similar kinds of work, who really come together at regular intervals to share what has worked for them, and share strategies and resources with each other, because they actually have, you know, they don't need to have an expert fly in and tell them what to do. A lot of the time they just need to actually come together. So there was a lot of appetite for, could we help them to, just on mental health and substance use, convene people who are interested in connecting on that on a regular basis. So, and we also asked them what anything else for service users. And the next, so again, this is sort of assuming we didn't talk to service users directly. So the next slide was just their, go to the next slide, and again, you can just populate that whole slide, what they thought service users might need. And they said, you know, some more low literacy ways to get at complex topics. You know, how do I talk about memory without using a lot of language? How do I draw memory problems? It's really some tricky problems they threw at us. And how can we use support groups? And how can we use something that happens in New West that we heard about, that was shared in the webinar, around cross-cultural communication. So instead of using just basic interpretation services, you have an interpreter who has not only the cultural background, but they can also add context beyond just language. For example, they will say, they can add what counseling is or why it's beneficial, so they can actually add some supplementary material, because so in that program in US, they call that the cross-cultural health broker program, where they want to really share how interpretation can be more adaptive. So we heard all sorts of really great things, and in both cases, the service providers, how do you want to be trained, and service users, number one preference, we asked them to vote on a whole bunch of things, is number one was like an in-person presentation or a conference workshop, so they can really relate with other people. And then same with service users, a community talk would be most effective. And then second most was, you know, either a webinar or video. And then things like, you know, brochures and audios and apps and things like that were lower down on the list. So we wanted to know, like, you know, are we redoing these 220 brochures? Clearly the answer was no. That, like, please talk, let's work on some of these workshops and videos and things first. So, and so where does this leave us in our, sort of my last little section? If these two arrows that you see are represented the two consultations, they both, you know, definitely pointed the way forward for us. I should mention with the BC Partners Group that I'm a part of, our focus is we can't change policies or fund new health services, unfortunately, but in scope for us is anything related to information, education, knowledge exchange, and we're looking long term. This isn't just the 2017 year that we're doing. This is a strategic priority area for us we want to do for many, many years. So we really see our role as finding ways to support you, frontline staff working with immigrants or refugees, to give you the right tools, help you share your tools with others, because you are already doing this work, and we just want to see if there's any ways we can, that we can help. So we realized on the next slide that these are our 4 opportunities that the first one might be the hardest for us to do. So in terms of feasibility, educating family doctors and psychiatrists is a little trickier than some of the others, but we might be focusing more around providing some practical knowledge, trying to develop some of the in-person interactive engaging strategies, and seeing if we can give some visual tools for managing those face-to-face interactions. And then the last slide is around our priorities for this year, this fiscal year. So you're interested. So be given all of the feedback we have. We are retiring the bulk of our translated materials. I'm here to help, and we're going to give people some other links to some other good translated material in Canada that they might want to use in the interim. And we're really going to focus on enhancing supports for professionals like you. And the next 3 bullets are they're really sub-bullets of that, but really the 3 things we want to do is engage with you to clarify which of those tools you'd find helpful for us to work on first, work with you to confirm priorities and formats and the content, and also explore the idea of how we can facilitate. I mean, we're not experts in this area, but how we could facilitate. We're experts in communities of practice, but not necessarily in this work that you do. How can we bring together some of the, not only you in BC, but even people outside BC who might want to share their wisdom here. So that is my presentation, and the next slide is just a reminder. So I'm Sarah, I'm on the right there, and my colleague Betty, I'm presenting on her behalf, but we're leading this work on behalf of our group. And please stay connected with us. If you'd like copies of any of the consultation reports I talked about, please let me know. And if you want to stay engaged moving forward around, I want to be connected to this emerging community of practice, or learn about these tools that you might be developing with us, we do have a quarterly e-newsletter where we sort of highlight multicultural mental health and substance use resources, and we're going to be profiling some of our progress in that newsletter as well. So that's another way for you to stay engaged. But please give me a call or drop me an email if this work interested you and you want to be a partner with us in developing the materials. So thank you.
So thank you, Sarah. Thank you so much for sharing. And if you have any questions for Sarah, please type them in the chat box, tweet us using the hashtag AMSA events, or send an email to events@amsa.org. So one of the first questions that has come in, Sarah, is, are there any plans to develop educational materials that can be used in settlement language classes to increase knowledge about mental health and substance use?
That is great. It's actually we heard a lot about community workshops, but I think this is the first time I've heard about a settlement language class. But I think wherever we can find where people are already, learning, connecting, whether it is those one-on-one sessions with settlement workers or they're actually going to classes, that would be ideal, because community talks, coming up with material, either embedding video clips or actually coming up with slides or other formats that you can use in those kind of sessions would be amazing. And we'd want to engage with people like you to find out, is this a 10-minute thing? Do you want PowerPoint? Do you want clips? Do you want someone to come in and do the talk? I think we still need a few more specifics so that we're not going off and doing something that's like, well, I can't use that because these classes are only 45 minutes long. So absolutely, that's completely in scope. So great question.
Perfect, thank you. Another question that we received is, thank you for acknowledging settlement workers are most often the first line of contact for newcomers. The challenge for settlement workers in the access to resources, example for mental health workers, referrals to the right psychologist, or referrals to mental health practitioners, perhaps there's a need for an increase in the health sector's effort in dissemination of these infos or programs.
If I'm understanding the question, it's more around like what some of those community services are, and that we really hope, because we work in mental health quite closely, that we could, just as you have become a bridge to us in understanding, helping us understand what some of the big issues are for newcomers and refugees, we're hoping in that system navigation work and resource that we develop, not only to help break down how the health system works, but also, and not just do it for service users, your clients, but also to have some system navigation support for you as a settlement worker around, well, this is the next step. So you know about MSP, you know what primary care means, and these are some tools to explain those concepts, but this is how you access psychologists in BC, and these are the 8 avenues that you can access psychologists, and this is how to find a psychologist who speaks another language, and this is how to find a clinical counselor, and this is the difference between those two groups, and we do that routinely because the Canadian audience doesn't know those things. So that's something that, again, we actually have some wisdom to share with your group, because it's not one that we don't interact with your sector very much, and that's why we were so excited to do this work, to realize that, oh my gosh, like, half our team are immigrants and or refugees or know them, and yet we have done very little in this work in BC, and so we're excited to share that, because there's a lot of communities resources available for you that you don't know about.
Thank you so much, Sarah. And a comment that we received was in Williams Lake, our advanced link class, and that's language instruction for newcomers to Canada, has mental health workshops monthly, supported by CMHA staff and other community partners.
That's super. So that's a comment already that they have found a way to link in, and I know the CMHA in Williams Lake, that you found a way to see. That didn't even come up in our consultation. This is why I was really excited to come here. I'm like, I'm not going to tell them anything they don't know, but it's going to be really good to hear from new people, because I'm sure that nobody mentioned the language classes. I've never heard about Link, and nobody, and all the people we talked to, talked about that as an opportunity to actually talk about mental health when they're ostensibly coming in for something else. But so often in my field, we have to do it through the back door, is like get them in on something else, and then mental health can be discussed in that context. So I'm curious, how did they go? How are they perceived, or how do they go if the person's still online in Williams Lake?
So yes, Sharon, if you're still there, we would love to hear some more. So the first is, through a partnership, they worked together to come up with a model. And the similar model was then used to talk about mental health in the workplace as well. So it's understanding, and I think that would be a great way to connect to you and Sharon maybe after.
Yeah, absolutely.
After this, is to talk a little bit more about how that partnership in Williams Lake did turn out.
Yes. Yeah, and then there's that whole untapped piece of mental health in the workplace for the settlement worker, again, based on all of the distress that you're having to manage, and all of the negotiation and the system navigation, and sometimes even the traumatic experiences, is how are you protecting your own mental well-being in the face of all of that, and all of the extra xenophobia we're seeing, and that takes a toll. I can totally see that taking a toll on my family, and so how do you protect your own mental health doing this, right? Because this whole talk isn't really about mental illness. Like, that might be for some people what we need to support them with, but it's actually around how do we protect all of our mental health given all of these stresses, and that includes you as workers. So I think probably settlement workers put themselves at the bottom of the list in terms of who needs support first, and that tends to be what happens in our sector a lot.
Great. Another comment related to this was that within the Link class context, Link teachers have speakers who come in routinely to their classes to present on various topics, and so being able to invite a speaker to talk about this subject would be a great add-on within a Link context.
Great. And so they present in English? And is there interpretation, or how does that work, not having been to a Link class? Those are questions I'm going to have to ask offline. But I'm very curious. That's awesome.
Yes, it is in English. So it's always in English. There are various different levels of Link classes, and that's dependent on the CLB level of the class, the Canadian Language Benchmark of the class.
Okay.
So the class would need to be tailored to the correct English language level of the classroom, and teachers are there to support their clients in understanding the speaker as well.
Okay, great. But yeah, no, absolutely. That's totally in scope, and that's a wonderful idea that nobody had raised yet. But they just mentioned community talks, but they hadn't situated the kinds that are already happening. So that's wonderful.
Perfect. And another question that came out that came up was, what successes have come out of this project? Have you seen an increase in access or understanding in the newcomer communities in terms of mental health and their needs?
Well, this project is really it's a bit of a fact-finding project. So I don't know that anything has really changed at the level of that a newcomer would see any different, because we haven't actually created any new resources. In terms of like the old project that was done in 2005 and all of those translated materials, I don't think the measurements were really in place to, we can track the downloads and things like that, but, did they actually help? That one I don't know. But what we're hoping to do is actually absolutely be able to measure with whatever resources we create, whether they're videos, in-person workshops, some kinds of templates and tools for face-to-face speaking, is to be able to measure in some kind of easy way if they hit the mark, if they were helpful, and then maybe follow up with a settlement worker over time to find out if people were able to understand that information and if it helped to clarify some questions that kept coming up in that community. So I think measurement will be something we'll be looking at, evaluation, but right now the measurement has been, we've been just doing a lot of research. So nothing's really changed, except that I'm getting invited, and I've just noticed not only that we had so many RSVPs for that webinar, and we were really, really humbled because we thought, we don't work in your sector, and we didn't think people would come, that there's really, I'm getting, whether it was an invite to this or someone's inviting me to his, he's wanting to resurrect the cross-cultural mental health conference that he used to lead, and wants Betty and I to be part of the planning group for that. So we're noticing that actually in the sector, people are inviting us now because we've engaged them. They're thinking of us and how we can work together. So I'm noticing a change in my work for sure. But I don't think that newcomers will see the benefit quite yet, but I hope it'll come in the next year.
Thank you so much. And yeah, I definitely think that the topic of mental health is something that is on the minds of a lot of individuals, also just being in the media. And so there's a lot of more information out there on newcomers' attitudes towards mental health change as they settle and integrate in Canada. How can we find out more information, or where are places where more information can be found?
About how
newcomers' attitudes towards mental health change as they settle and integrate in Canada.
Yes. Well, right now, one other piece of work that we're doing before the end of the fiscal is we're doing a bit of an environmental scan and a literature review. So we really wanted to talk to people in the community, but now we want to actually go back and see in the research, particularly in Canada, what have people found in terms of changes in what we would call health literacy, their ability to access and understand information and use it. What is that kind of trajectory? We know about that there's a lag between, well, we know there's a lag between when people experience trauma and when it actually shows up. But we also know there's a lag in terms of when people care about thinking about this topic or raise it. And I know we'll see that in the Syrian refugee situation, but we'll see it across the board. So I think we're going to go and just look at the actual published research to see what those arcs are in terms of how that changes and how long that changes to get into a very well-settled community, like many Chinese communities here, who are, as someone will say, are well-settled, and we may not want to devote a whole chunk of new resources there because they have so many supports. But yeah, it's a really great question. I really want to see how that changes. I know how it's changed in my family, but I think we need to look at the research. And we're also going to be doing something really interesting, and I hope people who are online right now, is we're going to be doing a scan across the internet and around what other tools, really low text, newcomer-friendly tools have been done, whether it's in health or outside health. Like, has someone created a really great video on like explaining the court system, like just trying to figure out people who have done this kind of work around like very common sense and easy to access information to deconstruct something really complex, and use those as kind of examples. I know that Fraser Health just did this series of really strong animated videos that explain how the health system works, and like our newsletter, we're going to share those. I would never have known about those videos that they created in like 6 languages if not for one of them being our key informants. She sent me the link. So that's what's happening, is we're hearing about more of these things, and we don't want to create something that's already been created. So So yeah, for people who are like, oh, we have this really great thing we've developed at our agency and we use that and it's really helpful, we're going to be asking really soon, hopefully with AMSA's help, to gather some of the things that you guys already use.
So yeah, if individuals who are listening have created something in their various organizations, please share it with us, and we'll definitely share it with you.
Yes. And I know you have some of your own as well as MSIS. You've got some really great tools and things, and so we want to just create like a bit of a catalog of all the really great things people have already done, and not just specific to mental health, but around this like really high, easy to access, high visual kind of resources, so that we can use that as a model moving forward. But yeah, if you know of anything within health or outside of health, like do let us know. Ideally in a Canadian context would be great.
Thank you so much. And I think we have time for one last question. Have you noticed any differences throughout the study and the differences in needs of information between refugees and immigrants?
Yes, well, I'd say probably it wasn't quite a 50-50 split in terms of the interviewees that we had, but I think perhaps not surprisingly the information needs for refugees, again, it's a lot around timing, because there may not be that that readiness or ability to think about mental health in the same way. Also, timing on their part is like there's less choice on their part in terms of versus an immigrant in terms of coming here now, and certainly more severe trauma, stress in many cases. So it can also be very stressful to immigrate. So I don't want to undermine that, but I think trauma was a big piece. I think timing was a big piece, and choice and control are huge pieces. And when you feel that you don't, and the culture of the neighborhoods and the communities that you're coming into, right? So we don't have the same conversation around immigrants. Well, maybe we are now, as we're having about refugees. So the visibility of a refugee group versus an immigrant group. But they have very similar needs in terms of needing. They also have very different health services. Refugees have different health services that they access and different funding that they access than immigrants. And so we were just reminded that don't glom them together into one group, because they actually have very, very distinct needs, but there's a lot of overlap as well. So we realized quite early we would have to develop something unique for both those groups at minimum.
So thank you so much, Sarah, for sharing the findings and the consultations that you have been doing, and really continuing the conversation with the sector today. So we're just going to take a short break now, and we'll be coming back at 12 noon for a lunch and learn on the topic of ending a fixed-term tenancy under special circumstances with the residential tenancy branch. So we'll be on mute until 12, and we'll be back then shortly. Thank you so much.
Thank you.